everyone. My name's Tim Coates. I'm a Professor of Emergency Medicine in Leicester, and I'm the chair of the Trauma Care Charity. We've still got people flooding through the doors because this is going to be a great session. But I think we'll make a start and we'll just do the introduction just as the last people are joining us. Can I start by saying a thank you to our sponsors? We put on these seminars for free, and at the Trauma Care Charity, we're delivering high quality education in an affordable way, but we get sponsorship for that. And thank you to Slater and Gordon, who are injury lawyers. They have a particular interest in trauma because they've got an interest in getting patients early rehabilitation sponsored by the insurance industry. The usual disclaimer on a trauma care webinar. Look, we talk about lots of different stuff here, but practice varies around the country, practice varies around the world. When you're practicing in your own environment, you need to follow your own scope of practice and the guidelines that your own organisation has. So the presenter can't hear or see you. There's a Q&A, which you might have to tap the little circle with 3 dots in the bottom that says more, and you can open up the Q&A. So if you have any questions, please put them in the Q&A, and the chat is for, it says it on the tin, doesn't it? The chat is for chat, Q&A. I'll be monitoring the Q&A, and then we can have a nice question and answer session later. There's a certificate of attendance at the end, and we'll put the link to that within the within the chat. The certificates have a small cost if you're not a trauma care member. If you're not a trauma care member, why are you not a trauma care member? You really ought to be. It costs about the price of a cup of coffee each month, and you get lots of good things and access. We've got our conference coming up really soon. If you haven't booked into the Armfield conference, March the 9th to 12th, have a look on the Trauma Care website. You're going to really miss out if you're not going to be there. Lots of really good stuff there. And why not just scan that QR code and become a member of Trauma Care? You'll get cheap tickets to the conference. You get the trauma journal access, and you get access to webinars and CPD certificates. So last month we had a really good talk by Fiona Leckie on the NICE head injury guidelines, and there were loads of questions at the end about older people who fall. So I thought, well, actually, we really ought to get a session on that because there was so much interest. So we've got one of the UK, or actually international expert on geriatric emergency medicine, Prof. Banerjee, who's one of my colleagues here in Leicester, to talk to us this evening. So I'll hand over to Jay.
Thank you very much. Good evening, everyone, and thank you so much, Tim, for inviting me to share some of my experience. Okay, so why am I talking about pre-hospital? So one thing I'll tell you first, I do not go out in ambulances. I'm petrified of being in them. I would feel sick. I'm not a pre-hospital person at all. But for 5 years, I've held the telephone supporting pre-hospital colleagues, mainly the vast majority being ambulance staff, but also general practitioners, community ACPs, providing guidance on community management to older people living with frailty. And as you can well imagine, by far the commonest complaint is a fall. So this talk is really about this. So over 5 years, I think I must have taken around 7,500 telephone calls on related to conveyance, non-conveyance, what kind of management. And in Leicestershire, we even have a whole load of GPs who exclusively work for this service to then go out and provide further management and support as needed to the patients. A large number of whom are from care homes, but certainly quite a decent number living in their own homes as well. So let's So of course, that is my experience bit, and I'm working in Leicester with Tim, which some of you know is a very busy department. We see around 50,000 older people every year. out of a total attendance of 240,000. It is still a small volume, but they probably take up about 65% of our total numbers conveyed in by ambulance. So it's a big thing. So what am I trying to achieve through this talk this evening? So we are not obviously going to learn everything about doing that. What I really want to do is push you a bit. Get into the zone of complexity. So make us feel a bit of discomfort, and hopefully I will succeed in doing that. So you may not like to know. I'm not going to leave you with any answers. I'm hopefully going to give you more questions. But what I will give you is some of the guiding principles that kind of support us in engaging in critical thinking, and therefore what follows is thoughtful action. So first of all, what are my biases? So I have had a very, very privileged professional career where not only have I not experienced, work in a fantastic department with brilliant colleagues, but I've also ventured and done stuff outside the department, outside the hospital, indeed outside of medicine. So I did a master's in education research, and more recently, I did a master's in medical law and ethics. And this is really to improve my own critical thinking skills, because each and every one of these people from these different backgrounds approach logic differently. So we are very much governed by a 2 + 2 = 4 kind of logic, which is very different to what a lawyer would use when they're trying to create an argument using case laws. It's very different. It's very important for me to learn those different ways of thinking, so that I did not stay cocooned within just one paradigm of thinking and acting. So as usual, let's start with a little case scenario, because that'll help me anchor and help you anchor what the conversation is going to be around. So constantly, when I keep talking of different things, keep your mind focused on this gentleman. So this is gentleman, as it says. You can read it. So this is a head injury on a anticoagulant. All right, so keep that person, that image, constantly in front of you as we proceed through the rest of the slides. So first of all, what can we do? So you are in that pre-hospital situation. You've got a gentleman, broadly speaking, 2 big courses of action. One, we take them to the hospital. The other, we don't do anything, and we put them back into bed. Okay, so we take them to hospital, but that is a reasonable outcome, can happen. Let's say this gentleman is very confused and he just rolls up the CT table and he breaks his hip. We put him back into bed and we do nothing more. Unfortunately, he dies 4 days later. Of course, immediately you're thinking, oh my God, he's died. So maybe taking him into hospital would have been definitely the right thing to do. But then now he actually can fall in hospital, break his hip, and that can also result in death. Maybe it is not the right thing to do. So what is the right thing to do? Both can be perfectly right. So what does it matter? What matters is how we approach that particular decision. So the key is not what we do, the key is how we do, because that is what we will need to justify. And we will come into that framework as to how we justify, and therefore how we think in order to be able to justify. Because remember, worse comes worse, if I'm to stand in a court of law, I'm standing in a court of law not because I am guilty, or I won't be standing in a court of law. If I was prejudged to be guilty for this gentleman's harm, I would be in prison or, standing in front of the GMC. But the fact that I'm standing in a court of law is because people want to understand why I did what I did. So the key thing here is not what is the right answer, but what is the right way to approach an answer. And that is what we need to be able to defend and be accountable for. So the reasonable course of action depends on lots of things. So first of all, we need to know quite a lot about the patient, including wishes and preferences. And remember, 2 in the morning, okay, you could easily have a very different course of action to 10 o'clock in the morning. Equally, you could have a very different course of action on 2 o'clock on a Sunday morning versus 2 o'clock on a Tuesday morning versus 2 p.m. on a Wednesday afternoon, because for those of you who work in the pre-hospital setting, you know it can be a movable feast based on where you are, what time of the week it is, what day of the month it is, what services are available at what time, etc. There's these huge variations. So we try to gather knowledge of the incident, knowledge of the patient, and of course, any previous, expressed, wishes and preferences, or even legally binding decisions, particularly in an incapacitous human being. And then, of course, what we also are expected to do is document the rationale for whatever we do. So one of the key things to remember is defensive medicine or any kind of defensive practice is not defensive. Just because I do a CT scan doesn't stop me, or I request a CT scan doesn't stop me from being accountable for any further harm that may happen. Whereas if the practice is reasonable, it is completely defensible. So the key thing to think about is not what is the right thing to do, but what is the reasonable thing to do. Remember, right and wrong are decisions that are arrived at in the future using an outcomes bias. When things go wrong, doesn't matter what right you did, people will question, did you do anything right? And what they're really now trying to understand is what you did, was it reasonable? Because that is what is the most wonderful word the law uses. Was it reasonable? So let's look at now an older person with a fall. So this is the way I approach an older person with a fall. There are three big things you need to think about. First one, what injuries have they suffered? And this is what we're going to spend a little time talking about. But briefly, I'm going to catch on and give you an intro to the other two questions, which I'm hoping you will take away with you when you're doing pre-hospital assessment in people or even in the ED. This is the standard approach. The first one, what injuries have they suffered? Second one, why did they fall? And third one, can you stop them from falling again? So first one, what injuries? We'll go to that. Second one, why did they fall? So the first thing to remember, a fall is always multifactorial. So unless this was an 85-year-old who was literally running for the bus and tripped on a loose paving stone and fell, chances are it was a multifactorial fall where cardiovascular, musculoskeletal, visual, auditory, sensory, other sensory, proprioceptive, all of these changes associated with aging will have played a role in precipitating a particular fall. And a fall by definition is a mechanical event. So this whole concept of a mechanical fall versus non-mechanical fall does not exist. They're all mechanical. And also another thing to understand is a fall is a geriatric syndrome. So there are these geriatric syndromes, delirium falls, polypharmacy, end of life, immobility, incontinence, all of these are called frailty syndromes. And there is a wonderful saying you must remember is frailty syndromes hunt in packs. So if somebody's a fall, they're very likely to have some other frailty syndrome concomitantly. So why did they fall is really casting a big net, not going in with a laser gun. And the last question, can you stop them from falling again? Well, the bottom line is you cannot cure falls. People who are falling, who have had more than one fall in the last 6 months, who are at high risk of falling, typically will probably fall again. So what we need to think about is how do we make that fall to be less likely to cause an injury? How can we make the response to that fall really, really rapid? And, all these kind of things. So basically providing a care package, falls clinic, strength and balance. So we are basically trying to optimize all these things. So let's go back to now the first question, what injuries have they suffered? And here we're going to really talk about major trauma, obviously. So as you know, major trauma is basically something where you get life-threatening injuries. So how come an old person falling from a standing height suffers life-threatening injury? Well, because the whole body has got a much lower physiologic reserve and the bones are much more brittle. So the bottom line is easier to break a bone with minimal trauma, and it's also very easy to suffer injuries inside with sometimes very little to show for it. You would have heard from the head injury talk that, a pre-hospital GCS is not a predictor of the degree of injury in an older person's brain because the brain has atrophied, there's a lot of space to take in, got a decent amount of blood, etc. But the bottom line is a fall from a standing height is the same as a 30-year-old being hit by a Land Rover Discovery at 50 miles an hour. It is major trauma, and that is what you need to think of. So think of that older person who's at the fall is equivalent to a 30-year-old who's just been hit by a Land Rover Discovery, and it just landed really heavily on the ground, on the street. So you're talking about suffering a whole pile of injuries. So every older person has suffered a fall, therefore should have a trauma survey. And any of us responding to older person who has had a fall needs to be competent in carrying out a primary survey. You talk about big things here. Being able to literally, where does it hurt? The numbers fine. Of course, there are all those challenges. The numbers may look fine, they may not be fine, which is why, a rough rule of thumb, if they've got pain in one or more areas, you're talking about, they need a proper trauma survey. If you're the person who can do it, well and good. If you're not the person who can do it, they need somebody who can. So the competency needs to be brought to the patient, or the patient needs to be taken to a competent practitioner, whatever. The bottom line is this is what the patient needs. Now, specifically, let's focus down to head injury now. So we've looked at the person with the fall, 3 questions related to a fall. We talked about major injury as a mechanism. Fall is a mechanism for major trauma. Now we're going to talk about that part of the head, very specifically this particular gentleman who is on an anticoagulant. So this is what the NICE guideline says, that if you have sustained a head injury, and remember, absence of external signs of head injury does not mean there is no head injury. So somebody's hit their head and have no other indications for a CT head scan, including basically no external signs of head trauma, but on an anticoagulant, the NICE says consider doing a CT scan. NICE does not say you must do a CT scan or should do a CT scan. It says consider. Now, it's really important when you look at any NICE guidance to weigh those words, because those words are very, very considered words. I spent 2 years developing guidelines for NICE and 2 years sitting on a guideline group. And I spent a lot of time learning of these things, but there's a lot of weight attached to those phrases. So consider means to think carefully about something, typically before making a decision. It does not mean you have to make the decision. It means you think every, which means you have to use a framework, because thinking always involves assumptions and critical analysis of what we are thinking about, documentation of the thought process. If we did not use a framework for thinking, as in we did not display critical thinking and we did not document the critical thinking process, then we wouldn't have a lot of leg to stand on, which is just one tiny part of the whole decision-making process, is thinking. So the first thing to think is we treat people, not conditions. We are not dealing with head injuries or a person or head injury with a DOAC or a case of head injury. We are dealing with a person. This is an individual who lives somewhere, has a family, has wishes and preferences, has thought about death. A lot of older people have already thought about death. So you're dealing with somebody where the playing field is very different. So we need to think of that, which means you need to involve people who know this person, so that we can tailor whatever we are going to be thinking about doing to the needs of this person and their wishes and preferences. And also bearing in mind that the condition of frailty. So when an older person is living with frailty, the greater the degree of frailty, what we're really saying is that lower their degree of resilience, and therefore the prognosis of them pulling out from a particular injury or an illness is uncertain. So this is not somebody with certainty. Therefore, if you're dealing with uncertainty, we cannot go in with guns blazing and then think later. We have to consider. And always remember, before you jump into anything, there are 2 sides to everything, and we'll come to how we weigh those sides to everything, and we need to share. And at this point, I would definitely encourage you, if you haven't already, to look at the NICE shared decision-making guidance. In my personal opinion, it's the best guidance from NICE ever. It's absolutely brilliant. Another thing to look at is, it doesn't matter what area you practice in, you can look up the BMA. SCI, the Social Care Institute for Excellence, also has a fantastic learning kit on the Mental Capacity Act, but BMA has got an excellent toolkit on how to make a best interest decision. When we say best interest, this is not medical best interest, it's holistic best interest. And remember, in case you don't know, capacity and best interest are legal concepts. So mental capacity is not a medical concept, it's a legal concept. So we really need to know everything about understanding, enhancing, appreciating capacity, and then acting on the basis of lack of or presence of capacity, and also the role of a lasting power of attorney. So all of these things are there. And then, of course, the risks of a DOAC. This is the nitty-gritty of the evidence-based medicine that needs to come in there. What is the risk of harm? What is the risk of stopping it? What are the risks of continuing with it after you've stopped it? What are the risks of a stroke versus risk of a death from an intracranial bleed? So all of these are coming in. So go back to the person. They're lying there on the floor. They've suffered a fall, mechanism of major trauma. They've got a head injury. They're on a DOAC. We're getting information on what to do. So we are coming at a point now. We have got lots and lots of information now on how we're going to approach this individual. We still haven't decided if we're going to convey or not convey. Okay, we still haven't decided if we're going to scan or not scan. We're still considering. Now, the next step is the medical ethics framework. This is called principled ethics. These four are absolutely timeless in the world of healthcare, and I would definitely encourage all of you to just Google it if you haven't come across it and read it up. So the first and foremost, we have to honor the patient's rights. Okay, we are allowed to make the wrong choices in life as long as we have the capacity to make it. Okay, this is the whole point of living in a society which allows us freedom. But with freedom comes accountability. With freedom comes choices that we need to make and need to justify. So non-maleficence as in do no harm. And just remember, medicine does as much harm. There was somebody who said that medicine, in its desire to do good, does a lot of harm. And we cannot lose sight of that. And then, of course, acting in the best interest of the patient. Also remember justice. Every time we're doing something and we're utilizing resources, we are not doing it for somebody else. So conveying somebody to hospital, that's tying up an ambulance, that's tying up the trolley. Getting that person into a scanner is tying up a scanner. We have, in a service where we're really being stretched, we need to be making sure that we're doing things that actually address the needs and wants of the individual, and not simply because we can do it or because we don't feel comfortable not doing it. So those are the zones of discomfort you need to address, and that is where the NICE shared decision-making guideline will help you, because it is absolutely brilliant. So what are the implications of clinical frailty score then? Because we haven't talked about that. So again, this is a paper based on data from Leicester, where we actually found that when you do a clinical frailty score at the entrance to the emergency department, you can use that score for predicting outcomes. And this was done, I think this data said about 54,000 individuals, older people with frailty scores. And basically, if the frailty score is 7 or more, there's 50% risk of dying within 1 year. And out of that 50% risk, the risk is actually highest in the first 3 months. So it's really important to understand that an older person who is severely frail or very severely frail is approaching end of life. We'll come to that briefly, because that's another important thing we will need to be thinking about, given those considerations that we are now dealing with an individual who is frail, who has got a uncertain prognosis. We have seen the ethical framework. We have looked at the best interest decision making. We have thought of the evidence base behind DOACs. We've thought of major trauma, head injury, NICE guidance, and we looked at the implications of CFS and what it means. And now we're going to move a bit sideways and think about the second scenario, where if we were to leave this individual might die, but they are, by definition, are probably approaching end of life. So how do we know? What is the definition? So these are obviously for the UK audience, and we will come to that. But first of all, older people don't do well in hospitals. Okay, this is really important to those of us who are managing older people outside the hospital, that when you pick up a person, bring them into the hospital, especially if they're frail, they have got a really high risk of suffering harm in hospital. Okay, so you've got increased risk of hospital-associated infections, hospital-associated delirium, and all of these have got a further risk of dying, falls, pressure ulcers. By the way, the Leicester data, which is very similar to the data that they published from Addenbrooke's few years before us from the acute medical unit, showed that out of older people being admitted who had frailty score of 7, 11% mortality within 10 days. So 10 days minimum average length of stay, 11% of these individuals died. Of course, the challenge here is that we don't know who is going to be one of those 11 out of 100 or 1 in 10. We don't know. Okay, so I'm afraid there is no tool that is going to tell us this is the individual who is going to die. We don't know, and because we don't know, remember, 9 out of 10 of them will not die. So the key thing is actually understanding wishes and preferences, understanding care plans, understanding what else we're dealing with, and sharing all of that information with the patient and the family, sharing the entire evidence, and our thinking process out loud is really what it's about. And then, of course, is the whole concept of, so who is approaching end of life? So end of life can be starting now, lasting for months or years. But typically, we are talking about, in case of general frailty, you've increased risk of dying within the next 12 months. And here you may have heard of the surprise question screening tool. Would you be surprised if this person were to die within a year? And if you're not surprised, it doesn't mean they are going to die. It means that they are at high risk of dying, which basically means you then start having the discussions about wishes and preferences. And because there is no right or wrong answer, if the individual wants to be brought into hospital for further care, that is what we do. But if the individual does not want to be brought into hospital for further care and their capacitas, or they have got expressed prior, very clearly expressed intentions, including care plans that say that, well, we need to respect that. Of course, it doesn't mean we leave them. It also means we look at other parts of, if they might die at the approaching end of life, could they die in the next few days? What is in place to support them if they do die? All of these need to be thought about. So approaching end of life and identifying end of life, that particular guidance, if you look it up, is really useful. The GMC also has a guidance on end of life care, but the NICE guidance is really, it's for all practitioners, and it's really, really useful in understanding what is it we're dealing with, and then sharing that with the family. Sometimes even asking the family, given the degree of frailty your mother is living with, given the degree of dementia they're living with, given how things have progressed over the last 6 months or 8 months, would you be surprised if they were to die within a year? And you know what? The vast majority of times the people actually know, because when you take them through the journey of what's been going on for the last 6, 8 months, becomes very obvious as to which way it is headed. And people, the vast majority of people in life are very sensible. Why wouldn't they be? If we think we are, why wouldn't the common public be? So it's kind of like taking them on that journey and that discussion. So everything is shared is really important. I'm going to give you a couple of slides on that kind of decision making, because for a lot of us, that thought is in the back of our mind. Surely we have to do every treatment. We have to do everything. Otherwise, if something were to go wrong, what would the coroner say? So I will let you read these 2 slides, because I think there's quite a lot to take in and reflect. So this is the famous Hillsborough disaster. And Tony Bland, a young man, was severely hurt and remained in a persistent vegetative state for 3 years until his family and the doctors both agreed that, that there was not much point in continuing to keep him on a ventilator, but ultimately had to go to court because this is the first time this question had been raised. They went to court. And this is absolutely brilliant piece of judgment, especially the language that was used. It's so incredible. I will let you read that and reflect on it, and then we'll move to the next slide, which will talk about the implications of this judgment for medical practice. Okay, so what does it mean? First of all, the best interest principle. Okay, it's really important. We must benefit the patient. Now, in our desire to do good, we are very biased against the harm. So when we're trying to admit patients to a hospital, we never think of the hospital-acquired harm, of the number of people who suffer. So I've got a PhD student who's just looked at 158,000 datixes. These are all older people datixes, and there's a very strong correlation between the degree of frailty and harm suffered in hospital. And actually, the biggest correlation between death and degree of frailty is the longer you stay in hospital, the higher your chances of dying. So hospitals are not magic bullets. They can cause as much harm as good. And when you're dealing with an older person who's approaching end of life, who is frail, a hospital is not going to change their risk of dying. It'll just change the way they die or where they die, and never forget that. So omission versus act is really important. This is not an illegal killing. We're not actively killing someone. We allow nature to take its course. And frailty is a complex condition, is a syndrome that but characterized by this loss of resilience. And as we become more and more frail, the body becomes more and more susceptible to lots of things like sepsis and falls, which actually take us to our natural end, which is death. Bodily integrity, sticking a cannula, a catheter into an individual, especially when this treatment is not serving a beneficial purpose, is it really what we want to do? Is that dying with dignity? And actually, this was the landmark judgment because it actually gave us this language of futile treatments. There are treatments that are futile, and treatments that prolong life without offering dignity. You really, really need to be discussing with the family all those aspects and with the patient if they have capacity before we jump in and do that. So basically, there's a lot to think about. But I can guarantee you, it'll take you about 10 minutes to do that entire approach. I've done it thousands of times, and it takes no more than 10 minutes to do that entire approach. Because once you keep doing it, you keep doing it, you keep doing it, you ask the questions of what matters really early, long before you've done the ECG and the blood tests. Okay, you ask that question long before you've done a set of obs even. What matters? What are we dealing with here? What are the priorities? Pardon me. And then we start having those discussions really early. It helps to have two people. One person does the assessment, one person carries on with the conversation, with the findings of the assessment, reinforcing the entire shared decision-making process. So I'm afraid there is no right answer or wrong answer when you're dealing with an individual like this. And guidance is a guidance. The law expects you to know how to apply the guidance. Society expects us to know how to apply the guidance. Just remember, law is nothing but the sane voice of society. And when law demands, well, it only demands a very reasonable and sensible course of action. So the key thing is, how do we address these uncertainties using a particular framework that brings these things together in a way that allows us to arrive at something which is mutually agreed? As long as the individual knows what it means to be treated versus not to be treated. What are the benefits of treatment versus the harms of treatment? The benefits of no treatment versus the harms of no treatment. And all of this has been agreed with and documented. You have arrived at the right decision. Thank you. I will stop there and open up for Q&As.
Thank you very much, Jay. You've started off a lot of conversations, which I'll try and bring together. Let's try and explore some of these areas. The first one that's come up is that we in the emergency services, whether it's in A&E or in the ambulance service, see one set of falls patients, but there's another set of falls patients which don't result in a call to the ambulance service, but result in a call to the out of hours GP services. And Peter and Deborah are having a nice discussion about this, and they're usually triaging these patients over the phone by talking to the care home staff. I just wondered of your views. I think you said that every patient should have a primary survey by someone who knows what they're doing. Well, that's this group. It seems quite difficult to get them a primary survey.
Yes, indeed. So again, remember we're talking about a primary survey that doesn't necessarily need an ATLS principle. We're talking about, are they breathing? The typical kind of triage questions we go through. Have they got pain anywhere? Does it hurt if you press them? Can they talk properly? Simple things. And then if we establish they've got pain in the chest, they've got pain in the pelvis, and the next thing I would want to know, is there any previous care plan that says if they fall, put them back into bed and don't do anything more, and there is actually somebody with the lasting power of attorney who can help us do that. Well, fine, let's move into those discussions. If the person is okay and at baseline, we have time to do all of these over the phone, and I've certainly done these. We didn't always deal with paramedic crew. We've dealt with ECA crew, with technician crew, and sometimes I would actually ask them to ask the carers to help us do assessments, because the carers know the individuals better than we do. And I think it's always using the available intelligence in the room and the knowledge in the room that is really important. And if they say that, this person is not like this, they've had a fall, they hit their head, and they normally are very, very chatty, and they've vomited, and they're really unwell, and they normally can wander around the whole place with their frame and say and have a chat with the residents. Well, I'm thinking, okay, this person that needs an assessment. In fact, this person could even benefit from having a CT scan and trying to do some interventions. So it rapidly becomes a scenario that is way beyond. Again, remember, there is no. I did not define what a primary survey was. I just kept it vague for that
Yeah.
reason. Is that you can utilize somebody else to do the primary survey for you. You don't have to send a crew to do that.
Yeah, and I guess there's such a lot of variation, isn't there? That's what makes this fascinating. That's what makes dealing with older people fascinating, is that you've got to take each case as an individual and sort of think about what are the factors in this particular case. We've got a very straightforward question for, very easy answer for you, I'm sure, which is, when is it safe to move a fallen patient?
Uh, So if that person is conscious, or let's say at their baseline level of cognition and at the baseline level of consciousness, and they want to move, I would let them move. It's as simple as that. If that person has got an altered level of consciousness, altered level of cognition, and they cannot move, I would definitely take all protection to stop them from suffering further harm.
Yeah.
But we see lots of older people who have got severely kyphosclerotic, kyphoscoliotic spines, all kinds of arthritic processes, and they hate being tied down. They hate being, kept like that. And the other day I had this lady with a orthodontic peg fracture who had sat at home for 4 days, and then rang the GP and said, every time I'm trying to lift my head, it hurts. And when the paramedics were bringing it in, they said, oh, should we not put a collar on? She said, do not touch my head. It's going to fall off if you do. And she came, and I just kept her like that and sent her for a scan. Obviously, unsurprisingly, she had a lovely fracture of her peg. And then she went home 2 hours later with her collar. Came back 3 days later because she wanted a shower and took her collar off, and then her husband couldn't put the collar back on, and so they came back into the hospital. And she suffered no harm because she's a fully conscious person and baseline cognitive. Well, she wasn't exactly a GCS 15. She had some cognitive impairment. So again, are they at baseline? Are they behaving in a way that they would? If they're not, we protect.
Yeah, I think there's quite a lot of comments around of the number of patients that the ambulance service get called to, where all they do after a 4 hour lie on the
Oh
floor
yes,
is pick the patient, pick the patient up, and the patient's then relieved that they can move, because there's this
completely.
sort of dogma that you mustn't move someone. They're telling
Oh
people,
yes,
you see so many, and I think there really is
absolutely,
some
absolutely,
education that we need,
absolutely.
and well-meaning first aiders are
Yeah,
not
yeah,
really doing the right
yeah,
thing here.
yeah, yeah. And while you're looking at the next question, I've worked with hundreds and hundreds of paramedics, as you would expect. Just like any other profession, the vast majority are extremely pragmatic and sensible people. They'll ring me and they go like, "This person been on the floor for 10 hours. I've got them up now. They've had breakfast. They've had a cup of tea. They've wandered around. Family are quite happy. Do you want me to bring them to the hospital because of a long lie?" And their Friday score is 6, and they live at home. They would care us 3 times a day, and they're very happy. And I was like, no, leave them. I'm totally happy with your assessment. They don't need to come to hospital. What am I going to do? Check their CK and find it is 600 and then give them a bag of fluid? Doesn't change anything. If they're eating and drinking, leave them alone.
Yeah. Now, lots of comments about geographical variation in the support that's available. Andrew, as a paramedic in Leicestershire, said he's very privileged to have you in the team. But can they expect it to be 24/7? And can they expect it to be rolled out to other counties as the pathway is so great for facilitating shared decision making? I can see your blood pressure rising.
So it's a really interesting question, and again, we need to think of those four principles. Autonomy, justice, but justice is a big deal here. If we were to start doing this 24/7, we wouldn't be doing something else. So we need to think about where is our need the highest. Another thing I'm hopefully, I haven't given you anything that you don't already know. So what I'm trying to say is that the kind of decision, and again, I can say this, having spoken to God knows how many hundreds of paramedics, as you know, Andrew, is that you know what you sort of need to do. You're just driven by instinct and experience to do the right thing. What I offer is an objective framework, which, if you were to stand in a coroner's court, you can't just say, I've done it loads of times, it felt right to me. You can actually say, this is why I did it, these are the reasons why I did it. So why do you need me to hold the phone for that? I could train, paramedics, pre-hospital practitioners, GPs to do exactly what I'm doing, and at the individual level. And I can tell you that for vast majority of patients, you would not need the telephone line. What you would need, though, is for your organizations to support you and to have a process that will stand by you when things go wrong. Because when you've done it 1,000 times, I'm afraid it is going to lead to a different outcome on 1,001th time. It is called the law of variation. There's nothing, nothing nasty about it. It is expected. And unfortunately, when that one thing goes wrong, the system comes down on people like a ton of bricks. That is where the problem lies, is the lack of safety we feel in making honest decisions because the system won't support us. But I think I have a solution, because with my medical law degree, I know I've got a framework which can be defended it allows for defensible practice, allows a reasonable approach, and I can easily teach that to anyone, provided your organizations support you in practicing like that.
Now, we're getting quite a lot of comments and questions around head injury and DOACs
Yeah,
again.
yeah,
Sarah, I think, was summing this up. She's both a paramedic and a senior ED sister. And there's that dilemma. You leave in A&E, we see people that have been left at home and have come in deteriorated after a
yeah,
little while with the slow
yeah,
bleed.
yeah,
But as a paramedic, she gets sort of advised to leave patients at home.
yeah.
So I think, as in your example, there is no perfect answer and there is no risk-free answer. How would you approach the pre-hospital head injured, bump on the head patient, not obviously severely head injured, who's
Yep, yep.
on a DOAC? How would you approach that?
So again, I will bring in all those facets. So the questions I will ask the crew, who are obviously my ears and my eyes and my mouth over there, is like, what degree of frailty are they living with? Have they got cognitive impairment? Are they in a care home? Have they got carers? Have they got a care plan? What kind of, how are they now in terms of behavior, baseline, etc. All of that. Okay, and then they clearly have a head injury, at which one I'll say, okay, so based on the degree of frailty, let's say the frailty score is 7, I absolutely know no neurosurgeon is going to operate, no intensivist will intubate somebody who is pretty much hoisted from bed to chair and back to the bed, or even somebody who has got, moderate to severe dementia and is dependent and could do things with prompts. These individuals, the intercostal muscles are so gone that you put them on a ventilator, they will never, ever come off a ventilator. So unless you work in a healthcare service that thrives of putting people on ventilators to make money for it, it's not going to happen in this country. We've got far too sensible anesthetists and intensivists who thankfully will not do what is very correctly defined in law as a futile care. So in those individuals, I will basically say, okay, so it's not going to be neurosurgery. So therefore, if you were to come for a scan, even if we do a scan, it doesn't change what we do, which is going to be hold your anticoagulants for 48 hours. You've got a risk of delayed bleed for 4 days. Okay. Or what we can do, not take you to hospital at all. We just hold your DOAC for 4 days and we restart, because you want to go back on it, because even though you're living with moderate dementia, you wander around, you enjoy, talking, laughing, even though you need prompts for everything, but you do have a quality of life. So therefore, I don't want you to have a stroke and lose that quality of life. So we're going to put you back on the DOAC and risk having a big bleed in the future with another fall and dying from it, rather than living horribly with a stroke. But we'll just hold it for a few days. And I must have taken at least, I don't know, at least 1,000, 1,500 calls with head injuries and DOAC. And I can tell you, not a single family insisted on bringing their parents into the hospital for a scan. They were absolutely happy. Things do change the moment they enter the emergency department. The expectations change, and a lot of these patients get a scan in hospital, which they would not in the pre-hospital environment, because the families are far too sensible, especially if they have had interaction with the emergency department in the past. They will go like, oh, no, it's a dreadful place. We don't want our father to go there, not if it's not to be of any benefit. But if you're leaving them behind, you need to give the right advice. So if they become unwell, call us again. No. If they become unwell, call your GP. They will need to institute end-of-life drugs, and that needs to be a very open discussion, because we're not doing anything. We're not going to do anything differently when this were to deteriorate. We know what might be happening. We need to be prepared for that. That is the key.
Yeah, that is, I think that's exactly how I practice that. I think the other scenario that I think Helen brought up is that, in the emergency department, you have someone perhaps with a bit of dementia who's fallen, had a bump on the head, but they're not going to lie still for the CT
Yeah,
scan. Are you going to sedate them? Absolutely not. You're going to sedate them. The risk of sedation is very much higher to that person, and they just need their DOAC stopped for 4 or 5 days, and then that's the only treatment that you're going to give, even if you see something on the CT scan.
yeah, yeah.
Um, that taking an old person to neurosurgery and ITU, was one of my consultants once said, you have to be really fit to survive being in ITU. Because
Absolutely.
anyone can do the neurosurgery, we can take a clot out of anybody, but actually getting them to recover, getting them to do the hard work of the physiotherapy and the rehabilitation afterwards, that is really, you've got to be fit to be able to do that.
Yeah, yeah. It just,
Quite a few comments of, yeah, great variation between advice they get from different doctors.
of
Yeah,
course.
I mean, according to DOACs, uh,
Yep,
isn't it a shame paramedics can't say hold the DOACs for 4 days? Well, you could do if that was on the if that was part of your organizational protocol, and
absolutely.
that's one of the things I know people are working at a
Yeah,
at a national level.
yeah,
Um,
absolutely. Yeah. Yeah, I mean, I did my own personal piece of research and decided, 4 days was absolutely optimal. You could do it for two, but 4 days was absolutely fine as long as you restarted within 7 days. The key was you have to restart within 7 days.
Yeah.
Yeah.
And what is it? I forget the sort of figures. Being on a DOAC decreases your risk of stroke by 5% in a year. If you divide
So,
5%,
so
if you
the
divide that by
NNP,
365 days, it's a
yes,
teeny amount per day. So the risk of being off your DOAC for 4 days
yeah, yeah,
is
yeah,
really, really
yeah,
small.
it is. It is, and it's perfectly safe to hold it for up to 4 days, and that even takes out the very few delayed bleeds at 48 hours. Yeah.
Yeah, I think a couple of comments about this stuff isn't on our protocols, so where does that leave us legally? Um, my disclaimer at the beginning was you need to follow your organizational protocols. You can
Yep.
argue to change them, you
Yeah.
can, engage, you can present the evidence and so forth. But yeah, the answer is that I don't know about legally, because legally you could probably
Yeah.
justify your decision, but organizationally you'd be in trouble if you weren't following your organization's protocol.
I think that is exactly the point. Is that legally you're going to be absolutely fine as long as you justify having had the discussion and reached a shared decision. Yeah.
Um, we've been talking about DOACs. Is it the same for warfarin hold for 4 days?
No, it's not. Warfarin is a very different beast. First of all, because it has got a reversal agent. So if you see a bleed, you would want to reverse it. And it's no near the safety profile of a DOAC. Um, I dealt with very few people who are on warfarin, because the only people still on warfarin happen to be those typically mechanical heart valves, although that will soon go as well. But all the head injuries I've had with warfarin, I have absolutely given them the option of coming into hospital, and I've dealt with very few, and they've all come in. They've all
Yeah,
come in.
yeah.
None of them had a bleed, but they all came in.
Interesting question from Emma here around a patient with dementia who fell and had a head injury, and just asking, do you think that people with dementia are treated differently when it comes to head injuries compared with someone without? Should they be treated differently? And if they are
Uh,
treated differently, is there anything the student can do to try and prevent this happening?
well, again, dementia is a spectrum. So it depends on the degree of dementia. It has to be tailored. So just like, there is no rule saying, oh, you're 85, you don't enter my theater. Well, of course you do if you're playing golf, and also based on what theater I'm doing. Equally, there's nothing, should dementia be treated differently? Of course not. Should be treated in exactly the same way. Treat the person, not the condition. So it all depends on the degree of dementia, the degree of frailty they live with, why they are on a DOAC, what would happen if you stop them, what do they want, what are their wishes and preferences. If somebody has got cognitive impairment, one of the key things to ask is, when you take them out of their normal area, what are the chances of them becoming delirious? Because that can actually cause as much harm as trying to drag them into a scanner to get a CT and sedation. You're opening a massive can here, but obviously this is an individual living with moderate to severe dementia. If they're living with mild dementia, well, I'll just treat them as anybody else, because chances are they're not going to be moderately frail, because there's a very good correlation between the degree of dementia and the degree of frailty. In that case, I will definitely, offer them the scan. I've had a lot of older people who have refused to come in. I basically said, you're a fit chap. I would like to be very happy to bring you into hospital and scan you. And they're like, that's okay, doc. I don't care. I've had a good life. I don't want a scan. I'm quite happy. I'll hold it for 4 days and get on with it. So
Just to clarify, were you saying that all patients with on warfarin with a head injury should go to the ED?
So again, it's a shared decision, but I would always offer them a scan. But of course, I would then spell it out that what are the downsides of them coming into hospital to get a scan. And in those situations, if they say nope, you're happy not to go, then it'll be a question of holding the warfarin, getting in touch with the GP to start reintroducing them again.
Excellent. A question from Peter here. What about developing a multi-disease agreed checklist, multi-dimensional agreed checklist to standardize care and give some legal support to decision making? You could trial it in the East Midlands, where DHU runs 111 plus most of the out-of-hours GP service.
So I have got a pre-hospital sort of checklist which I developed when I was working with NHS Select for use in the pre-hospital environment. Well, it's sort of checklist. It's basically got a pile of questions, including questions like, who are you treating? Are you treating yourself or the patient? It's meant to be support critical thinking. So I hate the word checklist, because it somehow distills the entire culture of practice into a piece of paper, and it can't be done. So
Mm.
so what I have is questions that just help you in asking the right things to arrive at a legal, ethical, evidence-based, shared understanding of what you're going to do.
Um, Peter, Jay's email is very Googleable, so I'd suggest you get in touch with him. Because if you've got an ambulance service medical director working with you, then that's good.
Yeah.
There's a few questions about long lies coming up, and in
Yes.
particular, long lie bloods, and how long is a long lie. So
Okay.
interesting. So
So there's
again,
a
people having rules that at
yes.
certain time you have to take the patient to the ED because of rhabdomyolysis. They have to have bloods to check that the lie isn't going to be harmful.
Okay. So first thing is 22 years working as a consultant in Leicester. I've seen rhabdomyolysis in an older person. I could count the number of times on my hand. And the most important reason behind that is because to have rhabdomyolysis, you need muscles. When you've got severe sarcopenia and you don't have muscles, you don't get rhabdomyolysis. Your CK never goes above 1,000, even after being on the floor for 12 hours. What you get instead is a grade 3 pressure sore because you don't have muscles, you don't have subcutaneous fat. It's your bones and the skin that pay the price. Now, what is the correlation between rise of CK? Remember, these studies are typically done in people who are much more fitter, but typically 6 hours plus your CK starts to rise, and your risk of a AKI associated with rhabdomyolysis particularly high after 12 hours. But remember, these are every human being is unique. You know, somebody who has got a lot of padding, you put them on the floor for 4 hours, they could generate enough creatine kinase to actually shut their kidneys down, where somebody could be on the floor for 24 hours and grade 4 pressure ulcers over the sacrum and the scapula, and they would have CK of 500. So there is no hard and fast rule, but a rule of thumb, if they can get up and walk around and eat and drink, what on earth am I going to do with them in the hospital? What is an IV fluid going to do with somebody who can drink and sit up and talk? I think, these protocols, remember, the job of a protocol is to pass accountability onto another person. It, in no shape or form, is going to protect you in a court of law. You follow protocol, person comes to harm, and you cannot justify what you did, the barristers will eat you alive because that's what they're trained to do, eat us alive. So the key thing is not to say, I did this because this was a protocol or because this was a nice guideline. I did this for this, and this reason includes the evidence, the guidance, the shared decision, the wishes and preferences, the ethical basis, understanding of legal capacity, mental capacity. All of these has to be in that approach.
Lots of consensus from around the country that the pre-hospital guidelines, either 1 hour or 2 hours, is a long lie. Given current ambulance response times, if you're transporting everyone that's been on the floor that long, that's quite a lot. There's a talk about the nice guideline of 1 hour of a long as a long lie. And a couple of requests that the British Geriatric Society come up with some guidance in this area. So maybe you could influence your colleagues in the
Yeah.
geriatric world. There's a few requests. Could we share information about withholding DOACs for 4 days and the stroke risk? I think the easiest way to do that might be when we put the YouTube video up. We'll put a couple of links in the text that's just under the YouTube video. Quite a few comments saying it's really nice to see common sense. We need more of it. And I don't think I can disagree with that. Look, that's really wide ranging. That's loads of stuff. That's, look at the number of comments that are still coming through here. I'm really
Yeah.
sorry that we can't do them all. We haven't got another hour that we can
Yeah.
spend doing this around looking at the incidents of rhabdomyolysis and so forth. YouTube video should be going up within a few days. Thank you very much for everybody that is here. I'm really sorry that we couldn't do all of those discussions. Jay, I think turn on the chat to see all the people saying thank you. I think people are really enjoying this. It's really made me think. I think it's really made the audience think here. On behalf of Trauma Care, thank you very much for supporting this webinar series. We couldn't do this and deliver this for free to this great audience without having experts like you coming along. Thank you to the audience for your support. Tom, if I could have the next slide, please. The way you can really support us, if you want to hear more of this quality stuff, is by scanning this QR code and becoming a member of Trauma Care. If you're not yet registered, if you're a student or first aider, it costs you the price of a cup of coffee a month. 2 cups of coffee if you've got your registration. That, I think, is a really, really good deal, and it supports us to do more of this sort of stuff. And next slide, please, Tom. Oh, yes, that's what I've been talking about. I'm sorry, I've been talking to the wrong slide to do that. £3 a month or £8 a month. This is the CPD certificate, which Tom has now created, which is a new slide. It's been a bit difficult, perhaps, getting CPD certificates in the past, but if you want your CPD certificate, just scan this link on your phone, and that will take you straight through to somewhere where you can get your CPD certificate. If you want it for free, just become a member of Trauma Care today and you'll get the certificate for free. If not, you'll have to spend a small amount. We've also put the link to the certificates within the chat. So I hope you enjoyed this webinar. Jay, it's been great fun. I always enjoy listening to you talk. If you don't want to become a member, but you want to donate to Trauma Care, we're happy to take money in any form. And as I say, that allows us to do more of this great stuff at a really low cost to our audience. So thank you very much indeed. Thank you to Jay. Thank you to the audience. And I'll say good night. Good night.